Thank you, Abhay. Thank you, chairpersons. Uh, I'd like to thank Professor Dean for inviting me here and Amit and the entire organizing team for inviting me here for this talk. In the next few minutes, I'll be talking about determinants of prognosis in alcoholic hepatitis. So before we go on to talk of determinants of prognosis, let's first uh, decide what is alcoholic hepatitis. So the clinical diagnosis of alcoholic hepatitis is onset of jaundice within the prior 8 weeks, ongoing consumption of alcohol more than 50 for females or more than 60 grams for males per day for more than 6 months, with less than 60 days of abstinence, AST more than 50, AST-ALT ratio more than 1.5, and both values less than 400, and a total bilirubin of more than 3. So this is a clinical diagnosis of alcoholic hepatitis, and this is generally a, if you terms talk in very pure terms, it's a probable alcoholic hepatitis diagnosis, and this is what I think most clinicians work on. We rarely do liver biopsies to really call it definite alcoholic hepatitis. So now with this definition, we'll talk of determinants of prognosis. So these will be my talking points. So the determinants of prognosis can be divided into two broadly. One is liver related, and we know there are various models available. The MELD score, the modified discriminant factor, the child score, and the Lilly score. And I'll also talk of some non-liver factors which affect the prognosis of alcoholic hepatitis, like nutrition and sarcopenia, infection, sepsis, renal dysfunction, and how alcoholic hepatitis presents. So if alcoholic hepatitis presents as ACLF, the prognosis is worse. And of course, recidivism is always very important when we talk of prognosis of alcoholic hepatitis. So these are various scores which have been derived over the last many decades. So the modified discriminant factor, which I think all of us use in clinical practice. So if it's more than 32, it is called severe disease. Then you have the child score, which has the bilirubin, albumin, INR, ascites, and encephalopathy. I think this is less commonly used for alcoholic hepatitis. We use it more for decompensated cirrhotics. MELD score, which has the INR, bilirubin, and creatinine, and a MELD of more than 21 is called severe disease. And I'll talk of this a little more in detail on what is the role of MELD in prognosticating alcoholic hepatitis. MELD sodium, the Glasgow alcoholic hepatitis score, which has age, white counts, urea, prothrombin ratio, and bilirubin. And then I already spoke of the Lilly score and the Abbott score, which is has the bilirubin, creatinine, age, and INR, and it is. But Abbott score and the Glasgow score are mostly used in Europe and not really for predicting 30-day mortality goes up to almost 100%. Now, the modified discriminant factor. Now, this is, I think, something we've all grown up with. I think MELD came later. Even when we were residents, we all worked with the discriminant factor. So Madry et al. First gave this score in 1978, which was based on prothrombin time and bilirubin, and they identified patients with significant risk for early mortality. This score was modified in 1989 to what we know it as of today, which is 4.6 into patients bilirubin, prothrombin in seconds minus control plus total bilirubin. And the patients with a score of more than 32 are considered to have severe alcoholic hepatitis. Now, discriminant factor is a valid index of severity of disease, identifying those at 50% risk of death within 2 months. It has an inadequate specificity and a sensitivity of 67 to 100% for short-term mortality. And this was shown in a paper in NEJM way back in 1992. So various studies have attempted to increase the cutoff of the discriminant factor and to see if it becomes any better, but they have failed to do so. So I'll show you more data that DF is probably now going out and MELD is what is coming in. Another score, which is the Lilly score or the Lyle score, as some people pronounce it. Now, this is not exactly a score of prognosis of naive alcoholic hepatitis. This is a score which incorporates 6 variables: age, renal insufficiency, albumin, prothrombin, bilirubin, and evolution of bilirubin at day 7. So this is a score which is used to predict a prognosis after giving steroids. So if a person has a Lilly score of less than 0.45, he has a 85% chances of survival versus Lilly score of more than 0.45, where the survival goes down significantly. So basically, if you assess the score at day 7, after giving steroids, we can decide whether to stop steroids, and it tells us about the prognosis of the patient. Another paper had come which sort of assesses the score at day 4 also, but has not been really validated. So this is a summary of the lab prognostic scores: the modified discriminant factor, the MELD score, the ABIC score, the Glasgow alcoholic hepatitis score, and the Lilly score. I think the MDF and the MELD scores are the one which we use commonly. The ABIC score and the GAHS are more commonly used in Europe, and ABIC more specific to Spain. MDF, like I said, more than 32. It's severe hepatitis, and it is an indication to start steroids. MELD more than 21, but it goes on a continuous scale, and it is not really used as a marker to start steroids, and it's a prognostic marker only. And Lilly score, like I told you, is the clinical use is to decide whether to continue or to stop steroids. So with all these scores, where do they leave us? So this is a very recent paper, a very good study published in the American Journal of Gastroenterology last year. More than 2,500 patients. The beauty of this study is that it is a very large study, more than 2,500 patients, 85 centers, 11 countries. So this is really a truly global study, unlike other scores which have been studied in a regional way. And what does this paper show us? That the ROC curve for 28 days and for 90 days is best for the MELD score. MELD and MELD sodium were almost similar, and then comes the MDF and the GAHS and the ABIC scores. So this study shows that the MELD score is probably the best score for predicting mortality in a patient with alcoholic hepatitis. And like I said, it's a global study, 11 countries and 85 centers. And so again, this is just some details of the cutoff which they used of 25 for MELD, and the sensitivity, specificity, both for 28 days and for 90 days was best with the MELD score. So this paper concluded that MDF should no longer be used to assess alcoholic hepatitis prognosis. MELD score has the best performance in predicting short-term mortality. So this is a very recent paper clearly showing that MELD is superior to MDF, which we often use. So the highlights of this study were that the MELD score best predicts short-term mortality in alcoholic hepatitis. The MDF score had significantly less accurate as compared to all previously validated scores. The MELD sodium did not further improve the accuracy of MELD, and there were no other independent predictors that could be added on to significantly increase the mortality prediction of MELD. So these were the highlights of the study, clearly showing that MELD is superior to other scores. Now, most of the scores we talk of are static scores, except for the Lilly score, which is a dynamic score, and again used, like I said, in deciding how to whether to stop steroids or to continue steroids. So this is a study published a few years ago in Gastroenterology, which assessed whether if we combine a static and a dynamic score, would it work better? So it was a joint model to predict survival after 2 and 6 months in derivation and validation cohorts, and it predicted outcomes significantly better than static or dynamic models alone. So they looked at MELD plus Lilly, MELD plus ABIC, MELD plus Lilly plus GHS, and MELD plus Lilly score did the best. So according to this joint model, for two patients with the same baseline MELD score of 21. So if there's a patient who has a MELD score of 21, two patients, the patient with a Lilly score of 0.45 had almost a twofold higher risk of death than a patient with a Lilly score of 0.16. So this study showed that by combining static and dynamic scoring for liver disease for alcoholic hepatitis, we can better predict outcomes in patients with alcoholic hepatitis. Now, coming to some non-liver areas where I think these are important in predicting outcome and determinants of prognosis in alcoholic hepatitis. So we all know the role of sarcopenia and the outcomes in cirrhosis or decompensated cirrhosis, or even determining outcomes after liver transplantation. So skeletal muscle loss or sarcopenia is a major complication of alcoholic liver disease. It adversely affects clinical outcome, including quality of life, complications of liver disease, and post-transplant outcome. Direct effects of ethanol and its metabolites, as well as the consequences of cirrhosis, including hyperammonemia, contribute to the pathogenesis of sarcopenia. And therapeutic goals include an improvement in skeletal muscle mass, as well as in the contractile function of the muscles. This is just to show how alcohol and alcohol-related disease lead to sarcopenia. So you have alcohol, ammonia, decrease in growth hormone, decrease in testosterone, accelerated starvation, and gut microbiome endotoxemia, all leading to muscle loss and sarcopenia. Now, this is a recent study published and which showed 149 patients. Higher MELD score was found in patients in the sarcopenia group when compared to the non-sarcopenia group, 21.5 and 24.2 respectively. Sarcopenia also correlated with significantly longer hospital stay, 17.2 days versus 12.4 days in patients with alcoholic hepatitis. There were higher risk of developing pneumonia, infections, and encephalopathy in sarcopenic patients. So alcoholic hepatitis patients with sarcopenia have significantly worse outcomes when compared with those without sarcopenia, including a severe form of alcoholic hepatitis, longer hospital stay, high risk of developing infections, sepsis, and hepatic encephalopathy. So clearly showing that, apart from scoring systems, sarcopenia is also important in determining prognosis of alcoholic hepatitis. What about infections? Infections, SIRS, sepsis, they're all important in determining prognosis in patients with alcoholic hepatitis. This is just to show how alcohol and immune dysfunction go together. And I'll not go into details of this. There's decreased phagocytic activity, increased complement activation, increased cytokines, decreased phagocytis, all leading to immune dysfunction in patients with alcoholic liver disease or alcoholic hepatitis. And there's a link between immune dysfunction associated with alcohol-related liver disease and susceptibility to infections and opportunistic infections. So if you look at this from abstinence to alcohol consumption to severe alcoholic hepatitis, the circulating immune cell function decreases and the systemic inflammation increases. So these patients of alcoholic hepatitis are more prone to infections and opportunistic pathogens. So these are various studies which in the table which show the prevalence of infection in alcoholic hepatitis ranging from 12 to 30%. And this last study by Lovat et al. Showed a baseline prevalence of 26%. Now, this study by Thurs et al., which was published in NEJM in 2015. So this wasn't really looking at infection. It was a study of corticosteroids versus pentoxifylline, but it also looked at infections in patients with alcoholic hepatitis. It is the largest study till date, and infections accounted for 24% of all deaths in patients with severe alcoholic hepatitis. Infected patients with alcoholic hepatitis suffer from a further increase in mortality of 30% at 2 months. So infections, again, is a major cause of death in patients with alcoholic hepatitis and a major determinant of a prognosis. And if responders to steroids get an infection, their survival actually becomes that of a non-responder. So infection, again, a very important cause of mortality and important prognostic marker. Another study which was published in Hepatology in 2015, 160 patients, 20% had infection at admission, 46% had SIRS, and 35% had multi-organ failure. And if you look at the table, the last one below, the patients with no SIRS had the best prognosis. Patients with SIRS without infection had intermediate, and those who had SIRS with infection had the worst prognosis in patients with alcoholic hepatitis. AKI or renal dysfunction, again, an important determinant of prognosis. This is a study of about 100 patients, which showed that the 90% mortality was significantly higher in patients with AKI than those without AKI, 65% versus 7%. Another recent study, large study, 773 patients of alcoholic hepatitis from 4 cohorts across the globe were randomly split into test and validation cohorts. 32% of the patients developed inpatient AKI in the test cohort. So again, if you look at the first graph, patients with AKI had significantly lower survival as compared to those without AKI. What this study also looked at was they formed an AKI score, which included the MELD score, hepatic encephalopathy, presence of SIRS, age, sex, bilirubin, INR, multiple other factors, and they devised the score in which if you had a score of more than 4, so an AKI score of more than 4 had the worst prognosis, and AKI score of 0 to 3 had a better prognosis. So AKI is clearly, again, a determinant of prognosis in patients with alcoholic hepatitis. I'm not going to go into details because ACLF is a totally a different ballgame, and I think there'll be separate talks on ACLF. But the prognosis of ACLF during the course of acute alcoholic hepatitis or severe alcoholic hepatitis also determines the prognosis. So this is a study published in Journal of Hepatology. 165 patients, mean DF was 66, and mean MELD score was 26 plus minus 7. The 28-day in-hospital death without ACLF and with ACLF 1, 2, 3 were significantly different. So patients without ACLF had 10% mortality, and those with ACLF 1, 2, 3 had 30, 58, and 72% mortality. 17.5% developed incidental ACLF during the course of alcoholic hepatitis, and their 28-day relative risk of death was 41.8. So ACLF is frequent during the course of alcoholic hepatitis and is associated with higher mortality, and infection strongly predicts the development of ACLF in this setting. And this is again editorial in the same journal, which showed that, talked about severe alcoholic hepatitis, which presents as ACLF, has a worse prognosis. And assessment of ACLF and multi-organ dysfunction are useful and consistent predictors of prognosis in severe alcoholic hepatitis. Last but not the least, so the determinant of long-term outcomes in alcoholic hepatitis is nothing else but recidivism. So this is a study published about 10 years ago, and abstinence at last follow-up remained the only independent predictor of survival in a multivariate analysis. So if you look at the graphs, alcohol use at the last follow-up, patients who are abstinent, the top line, are significantly better survival than those without abstinence. So the 5-year survival was higher in abstainers, 75%, compared with relapsed and continued drinkers, 26 and 21% respectively, with a significant p-value. But the survival benefit from abstinence only became statistically significant at 18 months post-discharge. So long-term survival in alcoholic hepatitis, probably recidivism is the only factor. What do various associations say as of today? These are all old guidelines, at least 3-4 years ago. So ASLD still goes with MDF and with MELD. MDF more than 32 and MELD more than 20 have a severe alcoholic hepatitis and poor prognosis. EASL still continues with MDF, but they also have the Glasgow alcoholic hepatitis score, which they base their treatment on, so that if it's more than 9, then you initiate steroids or other forms of treatment. So ASLD, MELD and MDF, EASL, Glasgow and MDF. So MDF is still there, but I think the 22 American Journal of Gastroenterology study shows that MELD is better than MDF. So my take-home message, various prognostic scores have been developed to predict outcome in alcoholic hepatitis. The modified discriminant factor is probably the oldest, and I think still the most commonly used. I think most of us still, because it's just an old score, we've grown up with it, we still use it. But MELD, according to recent data, better predicts outcome as compared to all other scores. The Glasgow score and the ABIC score need more validation across a more global population. The MELD and the Lilly score in combination is a good score to determine prognosis in severe alcoholic hepatitis. Non-liver parameters like sarcopenia independently predict outcome in alcoholic hepatitis. Alcoholic hepatitis presenting as ACLF portends a worse outcome. Infection, sepsis are common at presentation in alcoholic hepatitis and predict a poorer outcome. AKI in alcoholic hepatitis has a poorer survival as compared to those who don't have AKI, and recidivism determines the long-term outcome of alcoholic hepatitis. Thank you.